I'm Dr. Said Daneshmand from San Diego Fertility Center, and I have been in practice for about 18 years, and the majority of my practice now focuses on surrogacy cases and helping intended parents reach their goal of parenthood via surrogacy. So what I wanted to talk to you today about was how to maximize success, how to maximize the birth of a healthy baby pre-transfer and post-transfer. So we're going to talk a little bit about such things as PGS, the transfer itself, bed rest after transfer, the first trimester, and really what our goal is to talk about areas from the medical standpoint that could potentially increase the chances of a healthy delivery. So as you know, during the surrogacy journey, the uterus is prepared with medications, a combination of estrogen and progesterone. And what we do is we monitor the endometrial lining during about a 2.5-week period of time. The goal for the monitoring of the uterus is to make sure that we maximize receptivity of the uterus, meaning that we want to make sure at the time when we transfer an embryo, the blastocyst, into the uterus, that the uterus is most receptive to allow implantation to occur, and then subsequently to allow a healthy placenta to form, and obviously that would lead to a healthy delivery. So how do we do that? We do that with a combination of estrogen and progesterone. They have to be given at specific times. We start off with estrogen, and estrogen comes in pill form, in patches, and also in vaginal suppositories, and then we administer that for a certain period of time. After which, at a specific point, when we identify the lining of the uterus as being adequate by ultrasound, and typically what we want to happen is we want the thickness of the lining of the uterus to be above 7 millimeters or beyond, and we also want the texture of the uterus to be something called trilaminar, and that we talk about the three lines that we see on ultrasound monitoring. So we establish that, and we also look at hormone levels as we monitor the uterus in the first 2 to 3 weeks when the surrogate is taking estrogen. It's really important to monitor the hormone levels and the ultrasound. Many clinicians focus in on the ultrasound and the lining of the uterus. If we don't focus in on the hormone levels, any slight elevation in hormones such as progesterone can offset the endometrial receptivity and make the uterus receptive either earlier or later. And what that does, it changes the transfer time. So one of the ways in which we maximize the chance of pregnancy and implantation is by making sure that both the embryo and the uterus are synchronized at the same time, and we have specific protocols in regards to that. I've spent the last 10 years or so of my academic career doing research on endometrial receptivity. We published a lot of work on both frozen embryo transfers and fresh embryo transfers. So we have really honed in the time frame when the endometrium is most receptive to allow implantation to occur. Now, once the uterus is receptive in the first 2.5 to 3 weeks of estrogen administration, then we start progesterone. And that's when the clock starts ticking in terms of the embryo transfer. We administer progesterone, typically progesterone intramuscular injections, at the time when the uterine lining is adequate. And then that starts the time clock, essentially, for the embryo transfer. And we know exactly how many hours after the administration of the progesterone injection the uterus is going to be most receptive for embryo transfer. We're going to perform the embryo transfer at that particular specific time.